in the entire Australia-New Zealand area over a period of 12 years, they found that the mortality from septic shock as a group decreased from 35% down to 18% in 2012. And during that same time interval, no new treatment was introduced. We already had low tidal volume ventilation. We already had hemorrhage restriction in terms of giving blood. So what you're seeing here is that just by being a good doctor at the bedside, you can do well. But we can do better. So when we have our treatment priorities, there is a mantra that we should be saying, and that is that we want our monitoring to be continuous, because the dynamic changes in the physiology that we see in our patients probably tell us more than the individual static variables. And you heard a lecture earlier about in the operating room measuring cardiac output, and I agree. You also should measure blood pressure. Second, to the extent that you can be non-invasive and still get the data, be non-invasive. If you need to put in a minimally invasive catheter, such as an arterial catheter, that's fine, but to the extent that you can make it non-invasive will minimize the complications. And finally, what you care about is tissue wellness. You really don't care what the cardiac output is. What you care about is tissue wellness. We cannot measure tissue wellness, so we measure surrogates of it. And for that, we would measure oxygen consumption, lactates, metabolic acidosis. So you look at metabolic function. So the functional questions that you ask when you're resuscitating an unstable patient, the very first one is my patient in compensated shock? Because at that point in time, they don't have organ ischemia. If you think they have a low output and causing ischemia, the next question you would ask is, okay, if I give them volume, will cardiac output go up? Yes or no? Because if it will not go up, I shouldn't give them volume. Third, is the arterial tone increased, decreased, or normal? Because a normal blood pressure doesn't tell me anything. In my second talk tomorrow, I will discuss blood pressure targets. And finally, is the heart able to maintain adequate output under pressure without going into failure? And I submit to you, these are the only questions you really ask from a cardiovascular perspective of your patient. Well, if we focus in on compensated shock and ask, will the cardiac output increase? This is not a minor point, because when you look at postoperative complications, we see that if you under-resuscitate your patient, you have a significantly elevated amount of postoperative complications. But just giving volume until you can give no more is dangerous too, because over-resuscitation causes edema, poor wound healing, and excessive bleeding. That's in the operating room. Regrettably, in the ICU, the stakes are higher. We have less flexibility in terms of hypovolemia and volume overload, and so we have to titrate care much closer. One has to be precise in giving the right amount of fluids. So why don't we just give every single person who comes into the emergency room or from the floor who presents in shock volume? Well, Frederick Macquart and Jean-Louis Touboul looked at that, and they asked the question, if you give fluids to patients presenting with shock, either on the floor, in the emergency room, in the intensive care unit, will their cardiac output go up, yes or no? If the cardiac output goes up, they call them responders. The cardiac output did not go up, they call them non-responders. I'm actually an author on a few of these papers. I have no idea why that's there. There it goes. What they found was that 50% of all the patients who present in shock are not volume responders. Now, if you're a baseball player and you have a batting average of 500, that's pretty good. But if you're a doctor and you have a batting average of 500, that's pretty bad. because it means you're delaying the right treatment half the time. And if they're volume overloaded or in pulmonary edema, you may make them even worse. So what we assume is that venous return to the heart and right ventricular preload are the primary determinants of cardiac output, and we evoke Starling's law of the heart. And we assume if we have a small left ventricular end diastolic volume, we're volume responsive. And so we measure surrogates of preload. Those surrogates of preload have no relationship to volume responsiveness. This is just one example that shows there's no relationship between the change in CVP, or pulmonary artery occlusion pressure, and the change in stroke volume with fluid loading. Kamar went even further in their patients with shock. They could not find a single relationship between right ventricular filling pressures, here shown as CVP, and right ventricular end diastolic volume, or their change, or left-sided filling pressures, wedge pressure, and left ventricular pressure, or its change. And if you ignore the end diastolic volume, just say stroke volume. There was no relationship either. So if you learn nothing from this talk up until now, please learn this. Preload is not preload responsiveness. I can have a big ventricle and be volume responsive. I can have a small ventricle and not be volume responsive. The most common form of heart failure today is diastolic dysfunction. That's heart failure with preserved ejection fraction. And that shouldn't surprise you, because we've known that for over 100 years. Starling and ANRAP worked together in London after ANRAP moved to London from St. Petersburg, where he was working with Pavlov, the great Russian physiologist. What they showed was that, in fact, the heart has two responses. What we see in this human heart from a paper in 1959 is that here is your end diastolic volume, and this is an isolated perfused human heart, and you can see that this is your stroke volume. The heart gets smaller. All these investigators did to this viable heart is simply increase the amount of volume coming into it. And you can see the Starling mechanism beautifully occur. Note that as the end diastolic volume increases, the stroke volume immediately goes up. That is Starling's law of the heart. But look, over time, the volumes in the ventricle decrease, and in fact, the stroke volume stays high, and the filling pressures are actually lower than they were before, because what has happened is you've increased intrinsic contractility. That's what all your patients, except the ones with severe heart failure, do. In fact, the American Heart Association defines heart failure as those patients who need to use the Starling mechanism to sustain an increase in stroke volume. Okay? So I would never expect preload to respond to be preload responsiveness. But think for a second. With breathing, I change preload all the time, and I can use dynamic changes in preload to assess volume responsiveness. And to do that, I use heart-lung interactions. Since the heart is in the chest, increases and decreases in intrathoracic pressure will affect the pressure gradient for venous return to the heart, independent of the heart itself. And as I showed in 1984, with positive pressure breathing, the CVP rises, impeding venous return, right ventricular filling pressure falls, and right ventricular stroke volume goes down. And with Andre Deneau, we went into the operating room, and using transesophageal echo and automated border algorithm, we could measure left ventricular areas. And you can see that after a couple of beats, that decrease in right ventricular stroke volume causes a decrease in left ventricular end diastolic volume, and therefore stroke volume. So whether you like it or not, a positive pressure breath is going to alter preload beat to beat, and you can use the Starling mechanism to look at them, because that's an instantaneous change. So I can have a good heart or a not so good heart, and if they're underfilled, I will see that the stroke volume will vary in both ventricles. If I fill them more, the not so good heart won't vary much. The good heart will still have a response. Eventually, all hearts become non-volume responsive. So in collaboration with Jose Marquez, we went into the operating room, put an aorta a flow probe on the aorta and measured arterial pressure and did an IVC occlusion in human beings. This was the first time this had ever been done in humans. It took us 3 years to recruit 6 patients, and you cannot believe the consent form that we had to do this study. But we had, for the first time ever, real physiologic data in human beings. Here is the aortic flow, and here is the arterial pressure. And when you plot stroke volume versus arterial pressure over the physiologic range, they are linearly related. And I can measure pulse pressure on anyone. It's very easy to measure. And so in collaboration with Jean-Louis Thibault and Frederick Macquart, who was our fellow at the time, we quantified the changes in pulse pressure, not the systolic pressure variation, which is pulsus paradoxus, but the pulse pressure variation. And we showed that the greater your pulse pressure variation, the more your cardiac output would decrease if you were given PEEP. And furthermore, on PEEP, if you gave volume, if you had a high pulse pressure variation to begin with, you had a higher cardiac output. We then showed the exact same thing in patients with severe septic shock. The greater your pulse pressure variation on positive pressure breathing in septic shock, the higher your cardiac output. And furthermore, when you then gave fluid to the patient, if their cardiac output went up, their pulse pressure variation went down. And it doesn't matter what? Oh, I'm going to be a little bit. Okay, it doesn't matter if you measure platysmograph, it works. You can use aortic flow velocity, that works just fine. All these methods work. You can go to the right side of the heart, as Antoine Villard-Baron did, and look at superior vena cava collapse. It's accurate. You can look at inferior vena cava collapse. It's not as good. Or what the group of Philippe Vignon and Michel Slama, who was just here this morning, and Antoine Villard-Baron did, is they went into 8 ICUs and looked at every critically ill person, whether they had heart failure, tamponade, pulmonary hypertension, shock of any form, and they found that all the measures of pulse pressure variation and changes in velocity of the aorta and SVC volume change, diameter changes, predicted volume responsiveness. We propose, why don't you just look at the internal jugular vein, because you image it anyway when you're putting in a central line. And if there's a variability, as you can see here, you're volume responsive. If there's no variability, you're not. And when you combined it with pulse pressure variation, so you're looking at both the right and the left side of the heart, it's near perfect. If you are breathing spontaneously, you can just do a passive leg raising test. And when we examine that with Xavier Monet, you can see here's the esophageal Doppler of a spontaneously breathing person. As we gave, I don't know what's going on up here. Okay. That's the passive leg raise. That's the response to volume. If you had no change in cardiac output with passive leg raising, you didn't have a change with volume, and you can measure it with a totally non-invasive vascular impedance method as well. It works, and the data shows that's kind as well. So what we suggest is that if you are breathing spontaneously, you either do a passive leg raise and look at the change in cardiac output or give volume. So what values should we look at? Well, in an ideal world, we say a threshold value of about 15%. If you're below that, you're not volume responsive. If you're above it, you are. But that's not the way the world works. If you're worried about volume overload, you might give a higher threshold. And if you're really worried and want to give more fluids, you might make it lower. And I would say to you that in terms of the monitoring devices that we have available today, both non-invasive shown at the top, down to arterial, the totally, completely invasive, I am sure that you already have at least one of these devices in your hospital right now. You don't need to buy another device. You have everything. And the magic numbers are during positive pressure breathing, about 10 to 13%, which means if you can see a pulse pressure variation on the screen, you're volume responsive. But if you're just looking at the change in cardiac output, you need to measure it with a continuous cardiac output monitor, and the threshold value is 10%. And based on that, you can actually individualize the management of your patient. And I will just show quickly, I'm going to skip this because there's no time, that by personalizing it, by doing a stroke volume minimization, they could decrease the amount of time in the operating room on mechanical ventilation, ICU stay, and hospital stay. They could, by using this pulse pressure variation analysis, have less intraoperative hypotensive episodes and post-op complications. When they looked at lactate levels using this, the lactate levels in blue were lower if you were in protocolized care. And even for the same blood pressure, if you use the same protocolized care, the control group that didn't use stroke volume variation had higher complications. Most of the complications, however, were seen in the bowel surgery, which is known to be dangerous if you have ischemia or overhydration, both of which you want to avoid. And using pulse pressure variation or stroke volume variation, you minimized it. What this study showed, which was very nice, is you gave more volume early and less volume late in the post-op, and this time in the hospital was less. And by meta-analysis, even compared to the best we do now, if you do volume resuscitation based on pulse pressure or stroke volume variation to determine volume responsiveness, you decrease mortality and length of stay. So in conclusion, functional hemodynamic monitoring guided resuscitation will avoid giving fluids in a non-fluid responsive patient, allow personalized fluid and vasopressor resuscitation, and decrease ICU time and untoward events. I'm not going to go through the protocol, but it's published, and it's the one that's being used routinely now in 3 multi-center trials throughout Europe. And with that, I thank you for your attention.
Well, thank you for the honor of being here. It's a great pleasure to be at this conference. Actually, it's failing heart rather than ventricle. I have no conflicts related to this talk. So I'm going to start off actually with some of the principles I will use in my other 2 talks. So it's a little bit more general than this one, but I'm going to be using these same concepts as I build my other talks. So the basic approach I think of when I manage an unstable patient, I go to something very simple, which may surprise you, but it's Poiseuille's law, which is that a change in pressure is a flow times a resistance. So that means that blood pressure is essentially blood pressure as related to cardiac output times the systemic vascular resistance. Now it's a delta pressure, so you have a downstream number that we put in there, but it's small and we can ignore it. So the implications of that simple relationship is that a decrease in blood pressure or inadequate perfusion is either because the cardiac output is decreased or the systemic vascular resistance is decreased. It has to be one of those 2. So that's where your differential diagnosis begins at the bedside. An important principle, too, that I want to emphasize, because we often forget about this at the bedside, and that is that cardiac output determines the blood pressure. The blood pressure does not determine the cardiac output. That could be the subject of another long lecture. So blood pressure is cardiac output times systemic vascular resistance. What do we actually measure? Well, the blood pressure was measured. That's why you got called. But you also either measure or assess the cardiac output of your patient. One of the speakers said before, a very important monitor, look at your patient. So the first question you really ask in resuscitating somebody is the cardiac output decreased, in which case that is the problem, or is the resistance decreased, which you ended up figuring out because the cardiac output was normal. So that becomes central in your diagnosis. So if you can actually measure it, as other speakers have said, that gives you a really powerful tool to direct where you're going with the patient. So cardiac output itself is related to 2 things: cardiac function, which you've heard somewhat about today, and the return function. Cardiac function is heart rate, stroke volume, and stroke volume is afterload, contractility, and preload. The return function is stress volume, compliance, resistance, and right atrial pressure, which is common to the cardiac function and return function. So this talk is about the cardiac side of that. My talk tomorrow will deal with the resistance side. So here's the simple model that I think of. There is the return function, which is the tank filling the heart with a stress volume and an unstressed volume draining through a resistance, and the cardiac function, which is the Starling part of the curve, which will be today's talk. But I will briefly go through the return function because we need that, because that determines what's coming back to the heart. So thinking about how does blood actually get back and go around again? Volume creates force in the veins, a venous elastic recoil. So here is an elastic structure, a balloon filled with volume and a clamp at the end. And if I release that clamp, the balloon can empty. What are the principles affecting this emptying? Well, they're really quite simple. First of all, there's a volume that's left, the unstressed volume that had to just get the walls stretched. And that's the part that came out. There is a compliance, a stretchiness of the wall, and there is a resistance draining it. So the simple relationship is the stress volume divided by the compliance and the resistance draining that region. Importantly, only about 30% of your blood volume is stressed. The rest is unstressed and does nothing. So somebody my size, that means 1.3 to 1.34 liters are doing the work. The rest is doing nothing. And the compliance is a relatively constant value. Now, if I put more volume in and double the volume, then I have more to come out again. And that's what we frequently do with our volume management. We're just increasing the elastic recoil in the veins and venules and then increasing the rate of return back to the heart. Now, how does the heart come into this? Well, the heart is at the downstream end. So what the heart does, it allows that downstream pressure to fall. So it has what I call a permissive function. It allows the recoil to occur. Now, of course, it has a very other important function. It's permissive, it's restorative rather, in the sense that it's got to put it back again or you won't have any flow. But a crucial part of what the heart does is simply allow the veins to drain. If you have a patient that's arrested in front of you, and then you cut a large vessel, they bleed without the heart beating because that's the elastic recoil emptying out. Anybody who has a halal or kosher food, that's a crucial part. You have to cut the veins to let the blood empty because it won't come out unless you allow it to drain to atmosphere. Now, the compliance in vessels and veins is constant, but the compliance in the heart is time varying. So cardiac structures, the compliance varies over time. So on each beat, the ventricles become stiffer and then relax. And that's actually how they empty. And we call this a time varying elastance. So if I have a heart that constricts, it's becoming stiffer. It's what's really happening. If it's clamped, I have a rise in pressure without a change in volume, but if we allow it to empty, then at each time it empties, it squeezes the blood out of the chamber. So there's a change in pressure with a change in flow. So the rhythmic decrease in compliance transiently increases the pressure in the heart, and that's what ejection is all about, with valves making sure it goes in the right direction. So we have a cardiac function, which is Starling law, with preload setting the position on the curve. And we have this return function for the blood coming back to the heart, and these two intersect to create the working point, which is the cardiac output, the venous return, and the right atrial pressure. Now the pressure difference from that tub, that tank that fills the heart, is very small. It's only 4 to 8 millimeters of mercury. So small changes downstream with breathing or changes in heart function can very significantly affect the return of blood to the heart. Now, a crucial point is that the contraction of the heart occurs with calcium entering the cells, and there's a fixed time for that to occur. So this shows you an action potential, and in this case, this light signal is the movement of calcium into the cell followed by contraction. So you have calcium enter and you get your tension. But there's a fixed period for that to occur. And the plateau of the action potential sets the time that calcium can go in and make the contraction. So it's a very fixed period. So why is that important? Well, it's important when we come back to this time-varying elastance of the heart as described by Suga and Sagawa. So this shows pressure on the y-axis, volume on the x-axis, and we start off with the passive filling curve. As you fill the heart, it's stretchy, and it stretches with a fairly linear pattern, but then it becomes really stiff because you hit the limits of the pericardium or the cardiac cytoskeleton itself. Now, what Sagawa did is he took rabbit hearts and he put a balloon in the heart and a really high-fidelity pressure monitors so that he could measure the pressures instantaneously at different times. And he filled the hearts up to different volumes, just as Starling and Frank did. But he could measure the pressures at a fixed time after the onset of contraction. And he found that he would do this, let's say, for 60 milliseconds, and all the points landed on one line. And then he would look what's happening at 100 milliseconds, at 140 milliseconds, 180 milliseconds, and at any given time, from any given initial volume, all these points land on the same line. The slope of this line is elastance, or 1 over compliance. So as I was saying to you, what your heart does, it gets stiffer and then relaxes. The importance of this, there is a maximum to that curve for any given cycle. And that's because the calcium went in and is removed and it can't go anymore. So this becomes the maximum stiffness the heart can have in that beat given all the starting circumstances. And that is the best measure of its contractility and its function. So that's the end systolic pressure-volume relationship, which is elastance. So the end systolic pressure-volume relationship is the maximum elastance or stiffness the heart can obtain in the time available for each cycle. You can't go past that line because everything is retrieved and turned off. So there's two types of ventricular failure. One is forward failure. It's the failure to generate forward flow, an inadequate cardiac output because of that. And the second is a decrease in heart rate because of decreased contractility or increased afterload. Sorry, decreased heart rate, decreased contractility or increased afterload. There's also backward failure, which is reached when you reach the steep part of that diastolic pressure volume curve. That could be because of abnormal diastolic function, also because of failure to empty. So if you start with a high volume, then you got a lot less left over at the end, and just straight volume overload when we give them too much volume. So going back to this time-varying elastance, in this picture, these were all isometric. There was no emptying. But when the valve opens it, I lost a slide actually. So if we decrease the contractility, that means we couldn't get to that same stiff final point. And so our maximum point is now lower, which means the stroke volume is always going to be lower because I can't get to as high a value to empty. So forward failure occurs because the heart cannot reach as high an end systolic pressure volume line in the allotted time. This is one, got out of order. So to empty, this is what would occur. When I got to 140 milliseconds, instead of going all the way up, the valve opens and I get a stroke volume. If it went to 100 milliseconds, now I have more time to empty, I have a bigger stroke volume. If I get to only 40 milliseconds before the valve opens, I can have an even bigger stroke volume. So this shows you that important point that I'm sure all of you know, the less the afterload, the greater the forward flow, because you have more time now to have that ejection. But you still always end up at the same final line, you just have more time to get there as you eject. So on that previous slide, as I showed you, if that end systolic pressure volume line is lower, then the stroke volume is going to be lower. So the lower the pressure at the aortic valve opening, the greater the stroke volume because you simply have more time to get to that final elastance. So this is the classic pressure volume loop. You start off with diastolic pressure, which is your preload. The valve opens, which is approximately the afterload. I put it in quotation marks, but it's pretty close. You eject to that final line, and the slope of this line is contractility, with a stroke volume out and the stroke volume back. You have to remember that we sort of forget about this, but you put out a volume, but in the steady state, exactly the same volume must come back to the heart at every single beat in the steady state. And the ability of the heart to handle that becomes a very important part of what it can do. So in the steady state, stroke volume has to equal stroke volume return. So just taking that contractility failure point again, so here is a heart. We had different preloads, the same afterload approximately, and as we fill the heart up, as in the classic Starling's law, we get increasing stroke volumes. We can draw the classic Starling curve by taking those points, and we get this rising output to a plateau because we've reached this steep part of the passive filling curve. So this is the classic Starling curve with its plateau. So each of those points on this curve. Now remember, there's a plateau to that, and Michael alluded to this in his talk, that once you hit that plateau, more volume will not help. And it's flat, because this part is steep. It does not creep up, and there is no value in right heart failure of trying to jam in more volume. It will not help, and only cause harm. So the significance of the plateau, once reached, further volume loading does not change cardiac output. This is a diastolic limitation. Now, going back to forward failure, I said to you before that a decreased heart function is a flattening of this end systolic pressure volume line. So what that means is the stroke volume has to be decreased because it can't get to it doesn't have as long to eject. And on the cardiac function curve, that produces this downward rightward shift, as was shown to you this morning, or this afternoon, I guess. So this actually looks the same if you increased afterload, decrease heart rate, or decrease contractility. All three look the same on the cardiac function curve. So you have a lower stroke volume and cardiac output if the heart rate is constant at a given preload. Now, the importance of the Frank-Starling relationship. It's not so much actually the preload itself. It lets the heart adjust what's coming back to what has to go out. What Starling said was the greater the stretch of the heart wall, the greater the force produced, and the greater the output. And Michael showed a very nice figure of this. Preload is the force which sets that initial length before the muscle contracts. So it's preload that is actually the pressure, not the volume. However, the volume and the stretch creates the preload based on the stretchiness of the heart. Now, why is this law so important? It means that what goes in will go out. So here's an example. Consider a situation in which the stroke volume of the right heart was 101, and that of the left heart is 100. A 1% difference. Pretty good, huh? Imagine if your car is that precise to 1%. And the heart rate's 70 beats a minute. In this situation, in an hour and a half, your total blood volume would be in your lungs. Just do the calculation. 1 ml per beat, 70 beats a minute, work it out. An hour and a half, your total blood volume is in your lungs. It has to be perfect. It can't be off at all. That's what Starling's law does. It makes it perfect. What goes in must go out. It's the fine-tuning to match inflow to outflow. And that's really